All right, today we're tackling something we all see every single day, the kidney and electrolyte panel. But here's the thing. We're going to move past just memorizing what's high and what's low. We're going to learn how to read these labs like a story to figure out what they're actually telling us about our patients.
So you get that lab report back, right? It's just a list of names and numbers, and it can totally feel like you're trying to solve a puzzle. But trust me, hidden in that data is a whole story about your patient's kidneys, their fluid balance, everything. Our job, it's to be the detective and decode that story.
Okay, so like any good story, we've got to meet the main characters first. Let's break down the key players you'll find on a standard kidney panel. Think of this slide as our CAS list. You've got sodium, who's all about fluid balance. Then there's potassium, super important for the heart's rhythm. Creatinine gives us a clue about how well the kidney's filter is working. Urea tells us about hydration and waste products. And last but not least, eGFR. That's kind of like the kidney's overall performance score. So these are our main characters. Let's get to know them a little better.
All right, first up, let's do a deep dive. We're going to zoom right in on the electrolytes. Why? Because when these guys are out of whack, things can get really serious really fast.
First on our list is sodium. You can think of it as the master regulator of where water goes in the body. And get this, low sodium, or hyponatremia, is the single most common electrolyte problem you'll find in hospitalized patients. So yeah, understanding this one is absolutely crucial.
Now, here's the big takeaway for sodium, and this is a classic for any exam. You can't, I repeat, cannot interpret sodium all by itself. You've got to look at it with the serum osmolality. So if both the sodium and the osmolality are low, you're looking at true hyponatremia. This is where you start thinking about causes like SIADH, diuretics, or even Addison's. But what if the sodium is low but the osmolality is normal? Well, that could be pseudo-hyponatremia. It's kind of like a lab error where really high lipids or glucose are messing with the measurement, making the sodium look low when it isn't. Making that distinction, it's a game changer.
And one last thing on sodium, and this is a huge safety point. When you're fixing low sodium, you have got to go slow. I mean, really slow. If you correct it too fast, we're talking more than 10 millimoles in a 24-hour period, you risk causing a truly devastating condition called osmotic demyelination syndrome. So, remember the rule, slow and steady wins the race here. Okay, let's switch gears to potassium, and I really want to land this point. High potassium, or hyperkalemia, is a flat-out medical emergency. No ifs, ands, or buts. It can mess with the heart's rhythm with almost no warning at all. So what do you do? Well, your first clue is often on the ECG. You'll see those classic peaked T waves. And here's the crucial first step. Your number one priority is not to lower the potassium, it's to protect the heart. That means giving IV calcium right away. Then, you get that patient on a continuous ECG monitor and start playing detective to find the cause. You know, look for common culprits like ACE inhibitors or NSAIDs. Oh, and a quick tip for the other side of the coin, low potassium or hypokalemia. If you see that, always check the magnesium level. These two love to drop together, especially if someone's on a loop diuretic. And here's the thing, you'll have a really tough time getting that potassium up if you don't fix the magnesium too.
All right, we've covered the big electrolytes. Now let's pivot and look at the markers that tell us directly how the kidneys themselves are actually doing their job.
And the main event here is creatinine. So creatinine is just a waste product from our muscles. Simple enough. Our kidneys are supposed to filter it out of the blood. So the level in the blood gives us a pretty good idea of how well that filter is working. Simple, right? Well, there's a huge catch.
And the catch is this number, 50%. The creatinine level in the blood often doesn't even start to go up until about half of the kidney's function is already gone. Just let that sink in for a second. It means it's a really late marker of damage, which makes our next point so important. So what does that mean in the real world? It means one single creatinine number can be totally misleading. The really important thing that you have to watch is the trend. If you see a creatinine that's climbing, even if it's still technically in the normal range, that is a massive red flag for an acute kidney injury. You've got to watch the trend, not just a single snapshot. Okay, so because creatinine has its flaws, we have a better tool, the eGFR, which stands for Estimated Glomerular Filtration Rate. The best way to think about it is as the kidney's overall performance score. Now, it's not something we measure directly, it's a smart calculation that uses the creatinine level, the patient's age, and their sex. It gives us a much better picture of how well the kidneys are working. In fact, it's what the NICE guidelines recommend for assessing kidney disease. And honestly, this is the number that's going to guide a ton of our big clinical decisions.
Okay, so we've met all the individual players. Now for the really cool part, seeing how they work together. We're going to start connecting the dots and looking for patterns, because that's where the real detective work of diagnosis happens.
And this quote right here, it says everything. Whether you're studying for an exam or you're on the ward, the real skill isn't just spotting one number that's off, it's about seeing the pattern that all the numbers are making together.
And here is a perfect example of one of those patterns. The urea to creatinine ratio is this super useful little trick that helps us figure out why a patient has an acute kidney injury. So if that ratio is really high, it points to a pre-renal cause. That means the problem isn't the kidney itself, it's something happening before the kidney, like the patient is just really dehydrated. But if the ratio is normal, that suggests an intrinsic problem. Something is directly damaging the kidney. See? It's a simple calculation, but it's an incredibly powerful clue.
All right, let's take one final step back and see how we can use all these skills in practice by looking at how they fit into the official clinical guidelines for managing kidney disease.
When it comes to chronic kidney disease, or CKD, the NICE guidelines make it pretty simple. It's basically a three-step process. Step 1, you diagnose it. That's an eGFR under 60 that stays that way for more than 3 months. Step 2, you check for protein in the urine, what we call albuminuria, because that helps you stage the disease. And step 3, you make a plan to monitor them, which usually means yearly checks for anyone in stages 3 to 5. Simple as that.
Now, for an acute kidney injury, it's all about quick action. The checklist is pretty straightforward. You're going to monitor their labs every day. You're going to review their meds and stop anything that could be hurting the kidneys. Your absolute #1 priority is getting their fluid status just right. And hey, before you order a fancy scan, don't forget the basics. Just checking their urine output and doing a simple urinalysis can tell you so much.
And look, this is where all of this really hits home for patient safety. That eGFR number isn't just for diagnosis. It tells us how to dose some really critical medications. Think about common drugs like metformin or those direct-acting oral anticoagulants, DOACs. They're cleared by the kidneys. If you get the dose wrong because you didn't pay attention to the eGFR, the consequences can be incredibly serious.
So, there you have it. We've gone from looking at single, isolated numbers to seeing the bigger patterns, and then using those patterns to build a solid clinical plan. The next time a lab report hits your desk, I hope you don't just see a jumble of data. I hope you see a story waiting to be told. And the best part is, now you know how to read it. So the only question is, what story are you going to uncover next?